So this morning, I just wanted to give us a quick outline of what we'll be talking about. So why are we talking about hearing loss and falls risk? Why is this a topic that is important? Why is this something we might want to know about? I'm glad so many of you joined us today. I see that it is, a topic of interest for a lot of us. And why are we talking about this today? Why are Dr. Rosenblatt and I presenting? Why is this a topic that is sort of near and dear and of interest to us as audiologists? We'll also be talking about some common vestibular disorders. So vestibular being sort of the the part of the inner ear that is related to balance. So some of the things that might go wrong in those areas and some of the testing that we can do to help identify that. We'll also be talking about some other conditions that may contribute to falls that might be apart from just that inner ear function. And then of course, we want to talk about what can we do with all of this? What can we do to reduce our falls risk and who can help us do that? And of course, again, we'll have some time for questions at the end. So we're going to start just by talking about hearing loss. As you may have heard or read, hearing loss is quite common. So about 15% of American adults report some trouble with their hearing. Hearing loss is the third most common chronic physical condition in the United States. Certainly we hear about people having diabetes or cancer, those concerning conditions, but hearing loss is actually twice as prevalent as those conditions. As might be expected, those who have experienced extended exposure to noise, commonly via their jobs where they're listening maybe for long periods of time over many years perhaps, those individuals are actually 3 times more likely to have hearing loss. And certainly this is costly to those individuals as those people as individuals, and just to society in general. The economic costs are quite high as well. Those are estimated to be about $300,000 per person over the lifetime of every affected person. Individuals with hearing loss are more likely to have low employment rates, lower worker productivity, lower income, and higher healthcare costs. And those things certainly do add up over time. As common as that 15% is, it gets more common as we age. As many of us are aware, age is the strongest predictor of hearing loss among adults. And certainly as we get older, the prevalence of hearing loss does increase. So 1 in 3 people ages 65 to 74 has some degree of hearing loss. Among those 75 and older, about half of those people have some trouble with their hearing. Men are almost twice as likely as women to have hearing loss in adulthood. And what we see is that men more commonly have hearing loss a little bit earlier. But as everyone continues to age, women catch up there, and those statistics become a lot more similar as we all get older. When we're talking about hearing loss that happens as we get older, we're generally referring to presbycusis, and that's the age-related hearing loss. This is characterized by the hearing loss that happens sort of gradually as we get older. It tends to affect those high frequencies, higher pitch sounds first, and more severely. So as you can see in this graph here, if we're kind of looking at ability to hear higher pitch sounds by age, you can see that pretty steep increase as time and age goes. This can result in it sounding like people are mumbling. When you're talking to someone, it might sound like they're mumbling or not speaking really clearly. People often also report that they have difficulty understanding conversations in background noise. So if there is a lot of competing information, if you're at a restaurant or in a large group of people, that it's much harder to understand what's being said in those situations. We also might have difficulty with localizing, so telling where someone is talking from. And this can become problematic when you're in a group of people, and in order to keep up with the conversation, you have to be able to tell who's talking and where you need to shift that attention. So these are things that, we experience quite commonly as we get older, related to our decreased hearing abilities. Of course, our topic today is largely about dizziness and balance problems as well. These are pretty common and costly as well. So disequilibrium or dizziness among older adults is one of the most commonly reported things during short stay hospital admissions. So that might mean that an individual is in the hospital for maybe a different reason, but that it's something that they are reporting that they're experiencing while they're in the hospital. And it was the most common complaint presented to primary care physicians among individuals 75 and older. So something that really a lot of people out there are experiencing. There have been some postural metrics done looking at evidence of balance dysfunction. In this one study, they did a modified Romberg. So that's looking at how stable people are able to be in different situations. So looking at comparing how stable people are when they're able to kind of just stand still in a kind of a relaxed state, eyes open. And then we compare that to how someone is able to be when we have them close their eyes and maybe cross their arms over their chest to reduce some of the inputs that we get from vision or from our body. And that certainly does make it much harder to be stable, as you might imagine. So we see if someone is able to stand in that position for a minute. So when they did a test like this, 35% of US adults age 40, so not necessarily super old, age 40 and older, had evidence of balance dysfunction. So when they were asked to do that, they might have exhibited a lot of swaying or movement, or maybe even an inability to stay upright. When we look at individuals older, so age 80 and above, 85% of those individuals exhibited some difficulty with their balance in this condition. And among those with diabetes, those were even higher rates. So 70% higher odds among those with diabetes. When we look at the lifetime prevalence of vestibular vertigo, so that's a very specific type of spinning sensation that results in some problem related to inner ear function. That's about 7.5% or so. What's particularly notable, though, is that it's 3 times more commonly in elderly. And is nearly a 3-fold female preponderance, so much more common among females. And this is, of course, a big deal. This certainly can affect the things that we're able to do, interrupt our ability to do what we want to do, go where we want to go. So 80% of people reported that this affected their ability to continue with their activities, that they might have needed additional sick leave or time off from their job to help follow up on these issues. A significant number of people found that they actually had to change jobs or give up work or modify their work or change their ability to engage in some of the things that they wanted to because of balance difficulties that they were experiencing. And of course, there is always that potential for dangerous falls. When we're thinking about dizziness and balance problems, this slide might have been switched actually, but we're thinking about sort of a wide range of things. This might be vertigo, lightheadedness, fainting or passing out, maybe gait changes in the way we walk or move in space. And these may be caused by problems in the inner ear. So again, vestibular disorders. A lot of these can be treated, but very commonly it's seen that these are often misdiagnosed. And so it is really important to follow up with a healthcare specialist if someone is experiencing these things. Currently, about 70% or so of adults with moderate to severe balance or dizziness problems have reported that they've seen somebody about those difficulties. And with some of these initiatives, Healthy People, trying to get all Americans as healthy as possible, there is a national goal to increase that to 100% so that anybody who is experiencing significant balance or dizziness problems would know that they can see somebody and that they should see somebody and be able to do so. So looking more specifically at falls. Falls are a big deal, of course, and falls are the leading cause of fatal and non-fatal injuries among adults age 65 and up. More than 1 out of 4 older people falls each year, so more than 25%. And each year, more than 3 million older people are treated in emergency rooms for fall injuries. The annual medical costs total are over $50 billion. So this is quite common, and there's a pretty big impact of this. And what can be concerning is that, if you fall once, that actually doubles your chances of falling again. And 1 out of 5 falls causes a serious injury. 95% of hip fractures are caused by falling, typically from falling sideways. And falls are the most common cause of traumatic brain injuries. So if someone does hit their head, that can certainly cause some injury, some head injuries. And if our brain is affected, there can be sort of numerous things that can come out of that. And what is of particular interest to us is that people with at least a mild hearing loss are almost 3 times more likely to have a history of falling. Out of that same study, they found that the more hearing loss somebody has, the more likely it is that they have had a fall. So there's a definite strong link between those things. So I'm going to turn it over to Melanie Rosenblatt, Dr. Rosenblatt, and we're going to talk more about, again, why are we the ones talking to you about this today? So I'm going to turn it over to her.
Well, hello, everyone. Thank you for joining us. Thank you, Dr. Chung. That presentation has been excellent so far. I'm Dr. Melanie Rosenblatt, one of the clinical faculty and assistant professors here at University of the Pacific in San Francisco. So we've talked a lot about falls, a lot about hearing loss, and now we're going to talk about how we, the audiologists, play into this. We are the hearing and balance specialists. We're not medical doctors. And so any information that we share, we also encourage you to follow up with that with your medical primary physician or an ENT. But we, as audiologists, are in charge of hearing testing, recommending, fitting, following up care for hearing aids, programming and maintaining cochlear implants, and vestibular and balance testing. That's who we are. Okay. The arrow. Hang on. Left or right, click it. Okay, there we go. So some balance basics. Anyone who knows or has worked with me knows I love an alliteration moment. Our balance system, just some background, is composed of input from 3 of our systems: our visual or our ocular system, our muscle system or our proprioceptic, and our ears or our vestibular system. And these systems all work together. Information from each is integrated in our brain. So I guess our central system could be the 4th to help keep us upright and stable. All right. And for those of us who haven't had a full anatomy lesson, our ear has 4 basic parts. There is our outer ear, which consists of our pinna, which everyone sort of knows about. It's what we see. And that extends in, the outer ear extends into our ear canal. The eardrum is what separates our middle ear from our outer ear. And behind that, we have our ossicles, those 3 little bones, the malleus, incus, or stapes, or otherwise known as the hammer, anvil, and stirrup. We also have the eustachian tube, which connects our ear to our throat and allows for just ventilation and pressure equalization. And then we have our middle ear, our inner ear, which consists of our cochlea, or the hearing organ, and our vestibular system, which itself has 5 different parts. We have the saccule and the utricle, which are our otolithic organs, and then our semicircular canals, of which there are 3. And then, of course, we have our central system. The 8th cranial nerve connects our ear up to our brain. It is the vestibulocochlear nerve. It has several branches, but I won't get too far into that. Diving further into our vestibular system, we're going to start with our semicircular canals. We have the superior, otherwise known as the anterior, and that controls the pitch motion. So anyone who's ever flown an airplane may have a little bit of a vocabulary boost. So the pitch would be like if you're saying yes, nodding your head, yes, yes, I do want more ice cream. The posterior or inferior canal, it controls the roll or rotation around the x-axis. So if you were to drop your ear side to your shoulder. And then our lateral or horizontal canal controls the yaw or rotation along the z-axis, as if you were saying no. No, I do not want to continue to sit in this room and listen to this presentation. Our semicircular canals have a head a lump at the very end. And within that, we have the cupula and the cristea ampullaris, which control sort of the movement and deflection when the fluid within those semicircular canals is activated by a motion, either pitch, roll, or yaw. The deflection of the cupula will wiggle our little hair cells. The movement of those hair cells in the cristea ampullaris will send a neurotransmitter that travels up to our brain. Our semicircular canals do work in pairs, and they rely on an equal and opposite activation or inhibition. So here we go. Here's a good example of those pairs. The right posterior canal pairs with the left anterior canal. So when one is activated, the other is inhibited. You can we see how the fluid moves in one direction. And when it moves in one direction, that signal goes up to the brain, and this can help control our eye movements, which can go in either direction. And then, of course, we have the right posterior, which is paired to the left anterior. And then our two horizontal canals, which are not on this diagram, are paired together. The other part of our balance system would be our otolithic organs, or the saccule and the utricle. They control our linear acceleration. And because they don't sit on a perfectly flat angle, they are sort of tilted. You can see we are off the horizontal plane. They are their own functional pair. These otolithic organs have these little membranes. This membrane itself is embedded with this otoconia. These otoconia are calcium carbonate, and they are embedded in this membrane, this gelatinous membrane, and they move in response to linear acceleration, since the otoconia and the gelatinous membrane have different specific gravities. And as these fluid and otoconia move, they once again move some hair cells. The biggest and mightiest is called the kinocilia or kinocilium. And the movement of those hair cells once again generates a neurotransmitter that gets sent up to the brain for further processing. Here's a good example of how the movement of the linear acceleration of someone's head can move the otoconia, the gelatinous membrane, bend those hair cells, and then send up that neural signal. So what happens when this goes up to our brain? How does this information integrate? Well, we have three basic vestibular reflexes that help maintain and work with our both visual system and our muscular proprioceptive system. The first is the vestibulocholic reflex, or the VCR, not to be confused by that thing that's probably gathering dust under your television. The VCR maintains the head along a horizontal gaze. It allows our head to move independently of our trunk, but is limited by the range of motion of our necks. So not all of us are owls who can get a really good, 270-degree turn when we're trying to look over our shoulder. It is mediated through those otolithic organs and the vestibulospinal tract. Up next, I have a little video. I'm not sure if the sound will work, of a really good example of the vestibulocholic reflex. See if I can make this play. So we can see our good friend the chicken is able to maintain his head position independent of the movement of their neck or their body. This is the vestibulocholic reflex, and I want to thank Mercedes-Benz and their fantastic Super Bowl ad for that video. The next is the vestibulospinal reflex, or VSR. And this keeps us upright. It helps maintain our posture over our center of mass and center of gravity. And these are body movements, the reflexive body movements that help maintain and stabilize our posture. It also has two components, the lateral and the medial. The lateral vestibulospinal reflex comes for postural changes to compensate for tilts or movements of the body. And then the medial stabilizes the head in position while walking, so we don't go forward and down. I don't have a fun video for that one, sorry guys. The last is the vestibulo-ocular reflex, or VOR. We spend a lot of time focusing on the VOR. And this is focused on the concept that eyes move in opposition to the head. The eyes can keep the fovea of the eye, which is the part of the eye that helps us see best, keeps us fixated on an item of interest. And we've got the canal ocular reflex and the otolithic ocular reflex, the two parts. This uses input, the canal ocular uses input from those semicircular canals in response to angular acceleration or rotation. This is the primary source of gaze stabilization if you're moving your head. And then the otolithic ocular reflex, which is drives the translational VOR in response to linear acceleration, right? Coming back to sort of what those two domains of our vestibular system control. A good way to test your VOR or to see it in action is, if you want, you can take your thumb and hold it straight out ahead of you. Now keep your eyes focused on your thumb and turn your head. Your eyes will actually move in the opposite direction. That is the vestibulo-ocular reflex. Vestibular system, one side is sending an excitatory response up, the other is inhibiting and allowing the eyes to be pulled in the opposite direction of the movement of the head to keep them focused. Now let's get some basic vestibular vocabulary. What is vertigo? It is a term that is often misused or often used in a diagnosis form instead of what it is, which is a symptom. It is a sense of rotation. Alfred Hitchcock really did a number on that term. I think he confused it for a fear of heights. It is not lightheadedness, wooziness, general sense of or lack of stability. It is not that sensation we get when we stand up quickly and we get and feel like, oh no, our blood pressure has dropped. It is a real rotary sensation, as if you were being spun around and around and around. And then nystagmus is the other big vocabulary word that we're going to talk about. And it is an involuntary and repetitive flickering of the eyes. Movements can be vertical, horizontal, or torsional, implying that there is an element of rotation. It can impact our vision acuity, depth perception, and balance. It has many causes, including alcohol consumption, vestibular dysfunction, central involvements, genetics. And it can, of course, cause that sensation of vertigo, right? The flickering movements of the eyes can sort of simulate a sense of rotation. A lot of the testing that we do is looking for nystagmus. Do we see any involuntary movement of the eyes? Some basic disorders. We've got benign paroxysmal positional vertigo, or BPPV. We'll talk about that on the next slide because it is quite common. There's also a vestibular or labyrinthine neuritis, and this is a sensation of vertigo caused when there's been a disruption of function to one vestibular system. We mentioned earlier that there is a sense of equal and opposite and a balance, right? When one side is not sending good signals, it can cause a disruption to that, which can cause nystagmus. It can confuse our brain and our eyes, and that can cause vertigo. With vestibular neuritis, there is no involvement of the hearing system, so the hearing stays the same. But with a labyrinthitis, we are also working with the full membranous labyrinth of our inner ear, and hearing is also altered. These are, of course, diagnoses you would receive from your medical doctor, even if an audiologist is the one who is helping to do the testing. The next and often discussed disease or disorder is called Meniere's disease. This is a complex disorder, and it is a constellation of 4 symptoms, and they occur in episodes. They can last a couple of days. Vestibular neuritis and labyrinthitis can also last for a period of days, though they don't reoccur. Meniere's disease does tend to reoccur. The symptoms of Meniere's disease include episodic vertigo, so that rotary sensation that'll last a couple of days, and that also occurs with a fluctuation of the hearing. We see a low frequency hearing loss that is sensory neural, so it is of the cochlea. Also has a tinnitus or a ringing in the ears, often instead of being described as ringing, is described as roaring, like the mighty lion. And then a sensation of oral fullness, or the feeling that, oh gosh, my ear might be full of something, cotton, water, earwax, you pick it. The last disorder that we see quite commonly is called a vestibular migraine. It is like a migraine, but instead of having a headache, you experience dizziness, not often vertigo, but a sense of wooziness or unsteadiness, also episodic. Vestibular migraines do also have a neurologic component, just like the traditional migraine, and are often monitored by audiologists and ear, nose, and throat physicians, but also a team of neurology. We're going to come back now to that first one I mentioned, benign paroxysmal positional vertigo, or BPPV. I'm sure many of you have heard about those crystals in our ears. Those are actually those otoconia. They are calcium carbonate, not sodium bicarbonate crystals. And those are embedded, those otoconia are embedded in that gelatinous membrane in our saccule and our utricle. And sometimes they have gotten lost. They've worked their way out of their homes. If you think about pieces of fruit embedded in Jell-O, if the fruit were to work its way out, that is in effect what happens. And those otoconia migrate. They go from the saccular or the utricle into the ampulla, or that sort of head of those semicircular canals. This can disrupt the flow, the balance between the signals that are being received in the brain from our vestibular systems, and that disruption can cause vertigo. With BPPV, these symptoms, or those vertiginous symptoms, are brief, often lasting 30 seconds to 2 minutes, and they are provoked by a change in the position of the head or body, common examples being sitting up or rolling over in bed. There are 2 different types of BPPV. So those otoconia can lodge in 2 different places, either in the canal itself of the semicircular canal, which we call canalithiasis. They float freely, and they cause vertigo that is shorter in duration, less than a minute, 30 seconds, or cupulolithiasis, where those otoconia have lodged in the cupula. These last for a little bit longer, and with time and treatment, BPPV can go away. Now, it can affect all semicircular canals, though the most common is the posterior or inferior. Just because of the anatomy, it is sort of lower down, and well, there is gravity. So if those otoconia are floating through, they tend to drop down. But we do see lateral and or horizontal canal BPPV and anterior or superior very rarely. So we're now going to talk a little bit more about vestibular assessments, the most common being the video nystagmograph, or the VNG. And this is the basic diagnostic test that assesses both the peripheral and the central vestibular systems. It can help determine if balance difficulties are due to the central or peripheral involvement, or both. And it also has 3 major tests, the first being oculomotor, or the movement of the eyes. Oculo, eyes, motor, movement. We need to make sure that when we're looking at your vestibulo-ocular reflex, or your vestibulospinal or vestibulocolic, that your eyes are capable of moving in the direction that they need to. And if there is information being received at the eyes, the oculomotor muscles from the brain, that is unusual, then we want to note it. The next is, of course, the positional testing. This assesses the function of our otolithic organs for the most part, but also we do the diagnostic maneuver for BPPV as a part of this too. And if we see some signs of BPPV, I had a physical therapist friend just say, go ahead and treat it, because it's not that challenging to treat. And it can be life-changing and making you feel better. The last part, of course, we call the caloric irrigation. So we use temperature changes in one ear to disrupt that balanced neural activity between the left and right ears. And this can help, this has driven the vestibulo-ocular reflex, which we're now throwing out of whack, and actually does cause nystagmus and vertigo. We want to use this to determine if that vestibular system, both peripherally and centrally, the nerve, is able to communicate information up to the brain and how the brain interprets it. Patients usually don't love us after caloric irrigation. They tend to feel quite dizzy. The next test that we now have at our clinic at University of the Pacific in San Francisco is rotational testing, or the rotary chair. This assesses both left and right vestibular systems at the same time and can look at sort of overall central or peripheral weaknesses. And yes, it does look like you are going off to be sent off to space, and you're on a chair that sort of rotates around as if you were sitting on a desk chair and just spinning around and around. We can assess both systems independently as well as together from this. We also have a newer test called the Video Head Impulse Test, or the VHIT, and this looks at the VOR again using quick movements of the head. We're assessing all three pairs of semicircular canals on this. We've got the right anterior and left posterior, or RALP, not to be confused with everyone's favorite friend Ralph, and then left anterior and right posterior, or LARP. And then, of course, our horizontal canals don't get any fun nickname. We use a lag in the eye movements to determine if there's a weakness, and if so, is it more obvious or a covert, or an overt, sort of something that is more hidden but detectable through our cameras. And this can determine where we are in our own rehabilitation or compensation period as we are coming back from a vestibular injury. Newer tests as well are called the vestibular evoked myogenic potential, or VEMP. We use sound as a pressure. I know it's sort of confusing to think of sound as a physical force of pressure, but it is, right? As we're hearing, sound travels to our eardrum, moves the eardrum and vibrates those ossicles. And those, of course, enter waves into our inner ear, which, of course, as we've discussed, has the hearing and the balance organ. And we can use those sound pressure waves to drive a reflex, either the vestibulocholic through a cervical VEMP, or an ocular VOR response through the ocular muscles, the inferior oblique. So you can see here our patients have been set up. We use electrodes. We're reading electrical impulses from the muscles, either the sternocleidomastoid, or our muscle in our neck for the cervical VEMP, or, as I mentioned earlier, the inferior oblique muscle, which is directly under our eyes. These, of course, can give us more information about the otoliths and the function of the semicircular canals. The last test that I'm going to talk about is called computerized dynamic posturography, or CDP. This does give us information about both visual and proprioceptic and vestibular inputs in the level of our brain and controlling of our balance, and how disruption of those can make us more or less likely to fall. You are strapped in and hooked in, and this is something that is done both in physician offices, in audiology clinics, and also in physical therapy offices, and it is a good functional assessment. Not something you can have in your home, but it is something that, of course, we can seek out. And we want to look at how, of course, we are going to function in daily life. A lot of the tests I mentioned earlier are ones that give us information but don't look at the whole picture. And something like posturography really does take the time to assess us on a holistic level. They are designed, of course, to isolate how do the eyes and the ears work, or how do the muscles in the ears work when we take away one of those other systems. So we have some of the testing here. The first is sensory organization test, which is on the left. And that one we're looking at sort of how do we do when we're just standing and we're able to focus on our surround, that sort of Dr. Seuss looking telephone booth. Then what happens when we close our eyes? Do we move more or less? And our plate, the plate that our feet are resting on, is able to measure our weight and how it is changing in distribution. And then what happens when we take away the floor, when it's able to move independently, move in response to our movements? And sort of all of these can come together. We've got 6 assessments. And how likely are we to sort of experience a sway or a motion, or need to take a step in order to keep our balance? The other 2 tests are the motor control, and the adaptation tests. And those deal with movements of our feet or foot plate, right? How do we do when our surface is irregular, when it goes up or down, or when we translate forward and back? These can give us good indications of how we'll do maybe when we're on public transit. I know I have a hard time when the bus driver just hits the accelerator and we go for a little sudden start. But how likely is that going to yield a fall? That's what this test is going to help us with. Okay, I'm going to pass this off to Dr. Chung again.
Right, thank you. We've got musical chairs going on here. So as Dr. Rosenblatt shared, our balance system does take inputs from those 3 different systems. So just to review again, the vestibular system, all those complex inner ear workings that she just told you about, those help us sense movement. They give us information about equilibrium. And then that's joined together with information that we get from our visual system, what our eyes are telling us about what is around us and where we are in relation to the world around us. And then we've got that proprioceptive or somatosensory system where all the sensors in our skin, our muscles, our joints give us information about where our body is in space. This is especially important with regard to our neck, so how our head is moving and what's going on there, and of course our feet and our ankles with relationship to how they're getting input from the ground that we're standing on or the surface that we're standing on. We sometimes use certainly our hands to do that as well. So when we're feeling a little imbalanced, we might, of course, need to hold on to something, and that certainly can help us stay upright. But we might also find that just a little touch on something, it's not that that little touch on our finger is holding us up, but that information we get, that proprioceptive input we get from just that little thing can help us regain our balance and give us that extra input that our system needs to help keep us stable. So those 3 systems work together to give input to our brain, to our balance system. It does, as Dr. Rosenblatt said, also require that central involvement. So there in our brain is putting together the information it's getting from all 3 of those systems, and then it's making decisions about how to respond to that. So in the output side, our brain has to tell our feet what to do, our legs what to do, our spine what to do in order to keep us, again, upright and stable. So all of those things have to work together to keep us balanced and stable. And as you might imagine, if anything goes wrong in any of these areas, that can affect our ability to be balanced and stable and can result in a fall. So Dr. Rosenblatt nicely talked about a lot of common vestibular conditions that we may find and see in our clinic and that individuals might experience. So we'll talk a little bit more about some of the other things, those non-vestibular things that might affect any of those other systems that affect our overall balance and stability. So certainly anything that is affecting our brain, our central system, can affect our balance as well. So if there's anything causing our reaction times to be slower or to have more difficulty integrating all of the information that arrives at the brain, that can possibly contribute to a fall. If we have medication effects, so that might be something that, again, maybe makes our reaction time a little bit slower. Sometimes we get that sense of maybe fogginess from something as a side effect, and that might affect things. Certain medications do have as a side effect dizziness. And so too much of a medication or the wrong dosage of a medication otherwise can sometimes result in some dizziness or some imbalance or some things that can contribute to falls. Possibly other chronic conditions that many people experience may contribute to the risk for falls as well. 2/3 of participants in falls prevention programs have reported that they have multiple chronic conditions. By self-report, the top 3 of those are arthritis, heart disease, and diabetes. So when an individual is experiencing the potential effects of multiple conditions and experiencing those together, any number of those things may also be contributing to their risk for falls. As we talked about, the visual system being so important, visual impairments may have an effect, nerve and musculoskeletal problems, and a condition that Dr. Rosenblatt also alluded to, orthostatic hypotension. So we'll talk just a little bit more about those last few things as well. So for visual impairment, it makes sense that if we're having more difficulty seeing what's going on around us, that is going to make us more at risk for falls or not being able to respond to maybe to some of the things that are around us if we can't see them. So impaired vision actually doubles our risk of falls. And as we might expect, if you can't see it again, that is going to be problematic. And even more than just visual acuity, though, or visual sort of sensitivity, research suggests that contrast sensitivity and stereo acuity, or our depth perception, are actually even more associated with falls. So as a side note, out of the same study, they also found that hearing impairment was highly associated with falls as well, and we'll talk more about that. But contrast sensitivity, so that refers to our ability to see the differences between things, and that's going to affect our ability to negotiate an environment that has a lot of details, a lot of contrast. And in order to navigate that effectively, we need to be able to see those slight differences that might help us know there's a slight difference in the surface of the pavement or a walking surface or something that is approaching us. Our depth perception also contributes to how we judge distance and how the height or depth of something. So that might mean navigating that curb or the step down to the street or a stair effectively. So those things really can have a big impact on our safety in terms of falls as well. And of course, sort of a wide breadth of nerve or musculoskeletal problems can contribute to our risk for falls. Certainly reduced muscle strength, pain, amputations, orthopedic dysfunctions, so really anything that's affecting our legs or our feet. Even, the amputation of a single toe, for example, really is going to change the proprioceptive input that your brain gets. So that touch sort of information that comes in and the motor ability that comes out that contributes to our ability to stay stable. Neuropathy, so that might be weakness, numbness, pain, a wide variety of things that can be caused by nerve damage. Certainly any of those things can contribute to some problems that in our stability. This is most commonly happening in our hands or our feet. And again, the feet being very, very important for keeping us stable. And then orthostatic or postural hypotension is something that is very commonly experienced by us. So most of you have probably had some experience where you got up and you're like, whoa, and you just need a moment to get settled. So orthostatic, meaning upright position, and hypotension referring to low blood pressure. So what can happen is if we rise from a seated or lying down position, there can be such a quick change in our blood pressure that it causes us to feel dizzy or possibly have some blurred vision, some weakness, possibly even faint or experience syncope. We might feel nauseated or have some difficulty concentrating or have some confusion. The blood is not just able to move as quickly as it might need to help us stabilize. And so this is something, again, many people probably have experienced before. The treatment for this really depends on the cause of the disorder. Sometimes it might be as simple as just taking a little more time when you rise. It might be as simple as increasing your hydration. Certainly not having enough water can affect our ability to have our blood pressure stabilized, for our blood to move around effectively in our body. And so maybe just making sure that you're hydrated can make a difference here. Other diet modifications, medication changes, sometimes compression stockings can be helpful. But persistent or repeated episodes of orthostatic hypotension could be an indicator of other health conditions, so possibly heart problems or endocrine problems. So it is important to talk to your primary care physician or other specialists if this is something that you're experiencing. And then one of the other non-vestibular obvious things that could be affecting our balance, our propensity for falls, is hearing loss. So this is something we've kind of teased a little bit, so I'll just expand on that a little bit more. We have seen the evidence that adults, and not even particularly old adults, but ages 40 to 69 with even mild hearing loss. So that's defined as a 25 dBHL or poor hearing loss, are almost 3 times more likely to have a history of falling. So when they looked at a very large group of people and asked if they had had a fall in the past, those who had hearing loss answered at a 3 times higher rate that they had had a fall compared to those who had normal hearing. And even more, they found that as individuals had more hearing loss, their increases, their chance or the rate at which they had had a fall really rose with that as well. So for every 10 decibels of hearing loss, of worsening of hearing loss, the chances of falling were increased by 140%. So those are pretty big numbers and a pretty strong link between those things. So we have a couple pictures of an audiogram here. If you've had your hearing tested before, this may look a little familiar to you. So very briefly, when we look at this, when we do a hearing test, we're plotting your information on a graph like this. We're looking to see kind of how loud a sound had to be for you to hear it. If you could hear it when it was quite soft, the little symbols that we use are going to be closer to the top of the graph. If the sounds had to be louder in order for you to hear them, if your hearing sensitivity is poor, then the symbols are going to be closer on the bottom. So if we look at kind of that rainbow colored one, any symbols that were falling into that orange range, that mild indicated range, those folks who had hearing loss in that range are the ones who had, a 3 times, there are 3 times more at risk for falling. And then as we kind of move down into those other colors lower on the graph, those individuals have reported even a higher history of falls. So what might be some of the reasons that hearing loss and falls are linked in this strong way? So as it might be sort of obvious, certainly if you have reduced access to auditory cues, you might not be as aware of what's happening around you, which can increase our risk for falls. There's also good evidence that there's really important frequencies, particularly in some of those mid and higher frequency ranges where individuals are more likely to have more hearing loss. So some of the information located right there helps us kind of spatially orient and kind of echolocate almost, sort of like that, where we are in space. So when we don't get that information, we have a harder time being able to respond to it and, again, keep ourselves balanced and safe. There's also the factor of increased cognitive load. So our brains do only have so much capacity. And so having some hearing loss does typically require some extra effort to communicate. So it might be that as you're having a conversation, we miss a little bit of information. And so it takes a little bit of extra effort to kind of maybe fill in the gaps, or you have to concentrate a little bit more to follow a conversation. That takes away some of the resources that we might have to otherwise respond to things in our environment. We might also have some additional stress or anxiety about some of the things that we're missing, or worrying about, not being able to maybe hear the doorbell, or worry that you might have missed part of that important conversation or the message from your doctor. So all of those things can really be extra loads on our cognition, and it really takes up our resources and leaves less resources available to navigate around us. And then, of course, the hearing part of the ear, the balance part of the ear are neighbors in the inner ear. And so something that might affect our vestibular function or our hearing loss could potentially also be affecting our vestibular function. So it would make sense, certainly, that increased hearing loss also may have increased potential for vestibular function. And this is really important too when we think about falls. It's not just about the act of falling itself at one time. Falling can have emotional burdens as well. When someone has fallen, or when they may even have a fear of falling, when they might not have fallen yet, but realize that there is potential risk for that, there may be some fear around that. We may have anxiety or embarrassment or worry about that potential for falling. Certainly concern for reduced independence. So there can be a lot of things wrapped up into that. And all of those things together, knowing the risks, knowing some of those fears, that can result in us avoiding activities or going out and doing some of the things that we want to do. Certainly we want to be safe. We want to manage our risks. But that can result in people just kind of staying home or choosing to not participate in certain things. And that reduced activity can result in social isolation, just not participating as much in things, not engaging as much in things, and physical declines when you have a sort of a lack of motion. And unfortunately, that can cause a cycle. And all of that together can result in sort of ongoing declines in our various systems. There is something called sort of the cycle of falling, which talks a lot about this. And so we can sort of insert ourselves anywhere into this cycle and see how those things can often lead to each other and become sort of a continuous thing. So if someone does have a fall, it would make sense, and it's typical that we have a fear of falling again. That may cause us to have some reduced activity, which then may decrease our muscle strength, which then may change the way we're able to walk and ambulate and kind of navigate space, which then makes us, again, at even a higher risk for falling, which may cause another fall. And so that statistic that if you've had a fall once, you are twice as likely to have another one, that you can really see how that comes into play here. So what can we do about this? We don't want these things to happen, certainly. So big picture, of course, taking care of our overall health is one of the biggest things that we want to think about. So it is important, because of that cycle of falls, to stay physically active. The more we use our body, the more we're strengthening all those pathways along that vestibular system that we were talking about, and keeping those systems, those relationships, our responsiveness as healthy and strong as possible. So sometimes that might mean being a little bit more intentional about balance and strength training exercises. It's important that we get good sleep. It's easier said than done. I know I myself have not been getting the best sleep lately, and I have found that, I'll accidentally like clip a corner or misjudge something. I'm bumping into things because due to my, tiredness or lack of sleep, that makes us less responsive, less able to judge all of those things around us accurately. And it's easy to see how that really can contribute to our falls or otherwise affect our safety. Certainly avoiding or limiting alcohol are good ideas to contribute to our overall health and some of those issues that can contribute to falls. And overall, we might want to be thoughtful just about moving more slowly or more conscientiously. Again, really important that we stay safe. That being said, we want to make sure that we are doing so appropriately and not overly reducing our activity, because going back to that first thing, we want to continue to stay active and move our bodies. And then just being thoughtful about what we're doing with the rest of our body, keeping our hands free to give them the opportunity to give us that extra proprioceptive input by touching something, or have your hands free to grab onto something if you need to. If we are holding a lot of things, that also can affect, again, our ability to kind of have the right input we need to stay as safe and stable as possible. So I am one of those people that's always trying to like hold as much as I can as I walk through the house, or bring all my groceries in one go. But keeping our hands free is another way that we can really help keep ourselves safer. Around the house, what can we do? So certainly keeping walking areas tidy. So whether it's toys or papers or other things that can land on our floors, keeping those areas clear. So reducing the likelihood that we might trip on something or injure ourselves, certainly, or have anything unpredictable on the floors in our house, keeping those areas clear. Managing electrical cords. We have so many things that we plug in these days, and it can be hard to kind of do that efficiently with cords hidden and tucked away nicely. I know when it's been so hot in my house here recently, we've had to have a fan, and there's no good outlet for this particular fan, so often we have kind of a cord stretch. And we talked in my house about how that's not the safest thing as people are navigating those areas. So thinking about ways that we can manage that. We want to make sure carpets are secure, that those edges aren't coming up. If you have a transition from one type of carpeting in one area or from maybe hardwood floors to carpeting, making sure there's nothing that is going to contribute to a tripping hazard. Area rugs can be really tricky. As cozy as they are and as beautiful they are one of the higher risk areas for falls. those little edges there or their ability to kind of flip up can be hazardous. So being thoughtful about the use of area rugs around the house. We want to be careful of drips and spills. So it might just seem like a little spill when that, extra ice cube came flying out of your ice maker in your freezer. But that little bit of water could be hazardous. If you've been cooking around the stove and you've got some oil that's maybe made that area a little slippery, those are things that can be risky for us as well. So trying to make sure that we clean up those things and avoid any sort of extra slipping possibilities. And then our lovely pets that like to, follow us around and be underfoot and be near us. It's so fun to have them around us, and we love that they want to be with us all the time, but sometimes they can be a bit of a tripping hazard as well. So being thoughtful and careful about your pet potentially being underfoot and becoming a tripping hazard as well. Other things that we can do around the house, increasing the lighting. So particularly at night, when, if we get up to go to the restroom or go to the kitchen to get a drink of water, it's important that we have lighting along those areas. So whether it's keeping a night light plugged in all the time or having, there's quite a lot of motion censored options so that just when you need it, when you go into that hallway, when you go past that area, that light will light up so that you have more visual information to, again, give your system as much information as it needs to keep you safe and stable. We want to keep items within easy reach. So that will keep us from climbing too high. I'm a short person myself, so I know how it is to have to get a ladder, get a step stool to reach something on those higher shelves. But that can be a risky thing. Again, we have less proprioceptive input when we do that. And if we do have a fall, there isn't anything to grab onto or hold onto to give us that extra space. And the higher we fall from, the more dangerous that is. So if we can avoid doing that, we also want to avoid having to reach too far for something. So if we kind of have to really extend ourselves, maybe over our center of gravity or something that's harder to recover from, that can increase our falls risk as well. So managing where we put things can really help. Installing handrails might be helpful. So certainly on stairs, showers, toilets, places we need to get up from, having something to grab onto, or even, again, just to have that extra proprioceptive touch can be really helpful and at increasing our safety. When we go outside, we want to think about using safe footwear, so choosing shoes that are going to support our safety as well. So shoes with backs, shoes that you don't have to do funny things with your feet to help keep them on your feet. Wearing lower heels, high heels can, again, puts us in a different position. We don't have as much of that proprioceptive input as well, in addition to just having less points on the ground. Choosing shoes with non-skid soles. All of those things are going to be helpful. We want to watch out for those walkways. So keeping the paths and walkways outside our home, up to your door, out on your patio, clear of debris. Of course, any twigs, branches, leaves, those kinds of things. Even some grit or sand can cause that surface to be unstable and increase falls risk. So trying to keep that nice and clear. Being careful of uneven pavement. So it's really common as we're walking around out on the sidewalk or navigating the walkways of shopping centers or strip malls. A lot of those surfaces can be uneven. So watching out for those things and making sure that we're walking in well-lit areas. In San Francisco, in Stockton, we thankfully don't get that icy, slippery sidewalk usually. But even in poor weather, things can be wet and slippery. It's harder to see. That extra water can make things more glary and, again, of course, more slippery. And so we want to be cautious about when we do have to venture out in that, being more aware. You might also be holding an umbrella or other things that, make it a little bit trickier as well. So, and then of course, we can reduce our risk by managing our hearing loss. So as we saw, there is that very strong link between hearing loss and falls risk. So As one might imagine, if we are missing some environmental information because of the hearing loss, if we can increase that, that input that we're getting, that will help us stay more oriented and stay safer. And then reducing that cognitive load, that stress we were also talking about before. There is quite good evidence that hearing aid use and managing hearing loss really does reduce fall prevalence and risk. There was actually a really great study that just came out this summer, just a couple of months ago, about this, and they found that there is a 50 to 60% lower likelihood of experiencing falls or being at risk for falls when someone has been using hearing aids. There's an even stronger reduction when those someones are wearing their hearing aids consistently. So when they've worn their hearing aids for at least 4 hours a day, which honestly is not a ton, but at least 4 hours a day for a year. So that consistent, regular input really is helpful to our system and really does make quite a big difference in our ability to reduce our fall risk. Another study found that first-time hearing aid use cut the risk of a fall-related injury by 13 percentage points over the next few years after being fit with hearing aids. So some pretty strong evidence that this is something that is really helpful. As sort of a side note, there are hearing aids that have all kinds of fancy features these days, and one of those features are hearing aids that have fall detection. So you may have seen or heard something about this. Some hearing aids, they have that ability to detect a fall. So there is a sensor in them that detects sort of a rapid sort of drop in elevation. And it can be set up such that a text message could be sent to individuals, kind of emergency contacts that are set up in the app that's associated with these hearing aids. So if someone does have a fall, it could be set up so that a family member receives a text notification. They also have GPS in there, so you could even see the individual's location when they have had this fall. So there's some nice things that they're building into the technology to try to look and help us all stay as safe and be able to manage and treat these things as best as possible. So we're running a little bit short on time here. So this is just kind of a nice infographic summary of a lot of things we just talked about. This is created by the National Institute on Aging, and some 6 tips that are all things we've kind of talked about already as well. But getting that vision and hearing checked, doing strength and balance exercises, talking with our healthcare providers about our medications, taking care of things in our home to keep them as safe as possible, standing up slowly, using an aid if needed, a walker or a cane. All right. So we're going to wrap up here. Dr. Rosenblatt's going to help us close out.
Hello again. We're going to talk about sort of, I'm sure, a question that's on everybody's mind at this point, which is, am I at risk of falling? Is there anything that we can do to assess that, sort of simple and at home? And yes, there is. I would encourage that everyone who attempts this, of course, have a partner with them, somebody to help just in case anything goes awry. But there is a test, we call it a bedside assessment, that we've called the timed up and go or tug test. And it can provide a quick mobility assessment and falls risk. So to complete this test, you will need 1 chair, and we'll say a tape measure. We're going to have our chair seated. We need it to have a chair with a back, hopefully armrests, and then not a swivel or rolling chair. So we're going to place the chair and then mark 3 meters away, about almost 10 feet. You as the patient are going to sit, keep your back against the back of the chair. You're going to start the timer. You're going to stand up, walk those 3 meters, turn around, walk back to your chair, and sit back down. If you were able to do this in under 10 seconds, that's fantastic. That's normal. 11 to 20 seconds, that can show some good mobility and can ambulate alone. Towards the 20 or 21 to 30 second range, we may require some gait assistance. Now, what the literature has shown is that when our time is between 12 and 14 seconds, there has been an increased risk of falls. Again, if you're going to attempt this, please, please, please have somebody with you. And now we've done our little assessment, or you're concerned and want to talk to somebody or have other questions. What can I do? Who can help? Well, of course, the first person to look at is ourselves. Dr. Chung gave us many examples of ways that we can modify the home, modify the place around us to better set us up for success. You know, we can look at our shoes, make sure they're in good shape. Look at our slippers. Are they too slippery? Take up our area rugs. The list goes on. And of course, you can reach out to your medical doctor, your primary care, your ear, nose, and throat, or another specialist like a physical or occupational therapist. And of course, us. We are here. We all want you to be happy and healthy and live a good and full and accessible life. So as you need us, we are here and we want to help. With your medical doctor, you can certainly ask for referrals to physical therapy, to audiology, of course. We'd love to see all of you, and occupational therapy to assess more in depth our function on the vestibular and the hearing and mobility levels. And of course, here's our contact information. If you have any questions for us, please do not hesitate to reach out. And that is also a good way to have your physician contact us with the referrals as needed. Okay, and with that, we have concluded our presentation. Thank you for coming, and I think now we have a few moments for questions. Okay, so now should I stop my screen share? Yes. Okay. Here we go. Let's check our chat.
All right. So we've been here we go. Back together here. We've been lurking in the same room, trying to give each other space here. So definitely some time for questions. We did have our contact information there for the 2 clinics. We all provide comprehensive diagnostic and hearing aid services, as well as hearing protection, custom earplugs. Our Stockton location does provide cochlear implant services as well. And our San Francisco location offers vestibular and balance testing. If you have any questions about any of the services that are offered, things that are available, please don't hesitate to reach out to us. And we did have a slide in there as well, but welcome you to call us and schedule an appointment with us. And if a hearing aid consultation is something that we're interested in pursuing, having some time to do that. And then we are offering a free accessory if hearing aid purchases do come out of that. So please do mention that you went to this webinar when you call to schedule that appointment, just so that we can make sure we're aware of that when we see you for your appointment.
Okay. And so we have 2 questions in our chat at the moment. And the first is, does the use of a CPAP machine cause hearing loss? And unless I would say something is malfunctioning, the volume of the CPAP should not cause any permanent hearing loss. The next question was about testing services available in Stockton. And yes, our Stockton clinic does offer hearing testing, as well as hearing aid and cochlear implant services, though our clinic does not do any cochlear implantation operations. Those would be completed by a medical physician or an ear, nose, and throat surgeon.
So the specific tests that Dr. Rosenblatt mentioned for the vestibular portion, those are things that are done in the San Francisco clinic, but not in the Stockton clinic at this time.
Another question. Okay, we have another question about a vestibular schwannoma surgery. Any tips? Well, I would encourage you to follow up with your ear, nose, and throat or your surgeon from that. Vestibular therapy is something that they can also refer you to, as well as physical therapy, and of course, making any modifications to your home and areas around you to make you or to lessen the risk of any accidents or falls.
Yep. So vestibular schwannomas or other things that might cause a difference in our peripheral vestibular input. So that does contribute to that sort of asymmetry, that difference between ears that Dr. Rosenblatt talked about. And so having one side have lower function and the other side have higher function can cause some issues with balance or some sensations of vertigo. Our central system is quite good at adapting to this. So what it actually does is sort of down-regulate the other side so they become a little more equal feeling. So sometimes some vestibular rehab or therapy might be indicated to kind of facilitate that process. And so if someone is still continuing to experience some of those things, that might be helpful in addition to sort of managing the environment as we've talked about. And then
we have another question about the services covered by Medicare and insurance. So everybody's plan is different, and there are certain things, of course, that are plan specific. For some, with some insurances, Medicare and private or other insurances, with appropriate referrals, there will be some contribution for testings, whether it be vestibular or hearing, through the insurance. But Medicare, straight Medicare itself does not contribute anything towards the cost of hearing aids or amplification. However, some supplements to Medicare will have some coverage, but that is very plan specific. And we would encourage you to see your benefits guides, or you can reach out to your insurance to ask more specifically. Okay.
Any other questions? Feel free to type in the chat or unmute and ask any questions. And then certainly if you think of something later, you can reach out to your audiologist. I know we get to see many of you in our clinics. And again, this webinar is being recorded and it will be available online within the next several weeks probably. And you can also see recordings of past webinars on our website as well.
We have another question. Okay. So does this mean that the more one wears their hearing aids, the less they are likely to fall? The example given, when we're alone at home around the house, often not wearing their hearing aids because there isn't any conversation. Well, there are certain things that can happen around our house that we would want some auditory awareness of. Say if there is a spill of some kind or something falls on the floor that we wouldn't be able to hear without our hearing aids. It could increase the risk that we trip or slip or fall. And we certainly would want to sort of have that awareness. So yeah, I would encourage, even when we're home by ourselves, to keep those hearing aids on. Yeah.
I think, I think as we've seen, sort of the more input to our systems, the better, and the more consistently our brains are able to get that input, the better they know what to do with them. Yep, thank you. So Dr. Rosenblatt is going to put the contact information for our clinics here in the chat as well.
Okay.
So we'll put our phone number and then our website. We have a shared website between the clinics, so certainly that is a good resource as well. And that's upacifichearing.com.
Okay.
And then you can go ahead, I think we'll go ahead and submit that there. I think we also, and Dr. Awad has also put the address, and I think we'll add the phone number for the Stockton Clinic as well. There aren't any further questions. We thank you all for joining us today. Again, this is a topic that is near and dear to us, and I think of a really important interest for all of you as well. So I'm glad we're able to spend some time together this morning. Thank you for taking the time with us.
I hope you learned a little something.